dear friends. A warm welcome to all of you, our dearest friends of media, both digital and print, for having come to Slough in large numbers, so that we could share with you this feat that's been achieved by our doctors. It only shows when excellent clinicians join hands that they can do anything, and it can be miracles. So with a lot of faith and trust, Mr. Ian Papillon had come from Mauritius with the little twins. So much of trust that he reposed on Narayana Health hospitals, and today we are proud to say that the doctors of Narayana have given a new lease of life to this little child, this is the baby of Marie Papillon. Thank you. I now welcome our Honorable Chairman, Dr. Speedy Shunt, to come and take you through the journey. Please, sir. I would also welcome Dr. Ashley, Dr. Sanjay Rao, Dr. Riyan Shetty, and Dr. Shresha Maya to the dais, please.
Good morning. First of all, I would like to thank Ian and his lovely wife for trusting us with their little baby. Also, we are grateful to the government of Mauritius for choosing us over many other hospitals in the world to take care of the little kid with a complex heart problem. The problem of conjoined twins with multiple cardiac abnormalities. Clear Mary Papillon is a testimony to what healthcare today can offer to children born with complex heart problems associated with other problems of the gut and the rest of the body. Mauritius government had many options, but they chose us because of the previous experience our team had in dealing with conjoined twins. Priya arrived at our hospital 6 days ago, and obviously they withstood the long, very treacherous journey with a baby who was dependent on the ventilator, oxygen, and all the other supports. Baby had multiple problems. It is a very unique child, mainly because the baby it's a conjoined twin with one heart. But the rest of the organs were more or less separate. But the lung was in the baby, the little one who had no heart, the lung was also not functioning. Operating on children with a heart problem is complex. It is like people ask me what is so unique about heart operation. Heart operation is like repairing a plane when the plane is in the air with 200 passengers on board. Now, what is unique about pediatric cardiac surgery? Dr. Christian Bernard, one of my heroes, he made a statement that pediatric cardiac surgery differentiates the men from the boys. There is only a tiny number of cardiac surgeons who are trained to operate on the heart. Choose pediatric cardiac surgery because of the complexity. Now, what is so unique about Clea is that she is the first child to have survived an operation of separating the conjoined twin with one heart, and that heart is also, it is a complex heart, that heart had a complex problem called single ventricle with pulmonary stenosis. When the baby was with us, our strategy was to manage the baby well till the age of 6 months, because historically, whatever little case reports are available, the chances of separating the twins are very high if the kids are 6 months old. But Clea didn't give us a chance to reach 6 months old. When she was 1 month old, the little baby with no heart and a poorly functioning lungs was creating a lot of pressure on Clea to give the other baby more of oxygen, more of blood, and on the whole, both the babies were suffering. So we needed to take a call to separate the kid. But before that, we were very unhappy with the oxygen saturation. So Dr. Maya, our pediatric cardiologist, who will describe to you what he did a procedure on the conjoined twins by putting a metal tube called stent into the baby's heart. And this is the first time in the world a baby having a procedure of stenting of the duct when they are at the backdrop of conjoined twins. The baby got stabilized, and we thought we could now wait to reach 6 months for separating them. But unfortunately, when the baby was reaching 2 months old, it was getting very difficult for our pediatric intensivist to manage the baby's ventilation. One or other complication was happening, and the child, the little one, which was not with all the organs, was creating a lot of problems on the baby who was healthy and with the intact heart. So when the baby was 2 months old, we decided to do the operation. And first we separated the heart and all the great vessels supplying both the babies. Then Dr. Ashley and his team separated the liver and the gut. Dr. Ashley de Cruz will explain to you in detail. And how we could accomplish this on a tiny baby is because of the wonderful pediatric intensivists we are blessed with. We have a team of people who can manage any child with any illness as long as they reach the ICU alive. We have a fantastic team of pediatric cardiologists who can put stents and do interventions with children. We are blessed in having a huge number of cardiac surgeons who do the largest number of heart surgeries on children in the world. We have extremely competent nurses who can look after any kid in any shape, in any complex problem. And we have pediatric anesthetists and the radiologists who can interpret all these images. It's a very complex area to interpret two babies sharing a lot of organs. So essentially, CLEAR is a testimony to show what this country can offer in terms of saving precious lives. And I would like to now request Dr. Ashley de Cruz to explain to you in detail about the complexity of various interventions on conjoined twins. I'm extremely grateful to all of you for sparing your time and be with us today. Thank you.
Good morning. If you don't mind, I'll just speak from down here because then I can see the slides. I don't have a display in front of me. Otherwise, I'll be turning back and talking to you. Is this mic working? So, conjoined twins. That is, first let me start. When you do complex operations on conjoined twins, it's not possible in every place. It's only possible where you have an institution that can support such operations, which means you need resources, you need manpower, and you need all the equipments that go into looking after these children. And we are blessed in Narayana Health to have that, so that we can undertake these various procedures. The other thing is that we have every type of intensivist with highly trained physicians in each of these departments. And I must tell you that without them, we cannot do these procedures. It's not possible. So as you see that list there are so many people who were involved, not least the last line, our nursing staff, our nutritionists, and our physiotherapists who take care of these babies on a daily basis for almost these 5 months. Our first set of twins that we separated was a long time ago. These were babies who were joined at the belly button with a little bit of the liver. It's not very complex to do, but this started our journey, and we got to understand a lot of complexity of how to give anesthesia in conjoined twins, how to deal with two separate circulations, somehow joined together by some tissues in between. So this gave our anesthetists and the intensivists a lot of experience, apart from us, of course. So it is a tribute to the teamwork that we have that we are able to accomplish these procedures. So what are your readers and your friends might like to know, how does this happen and why does this happen? So I just roughly take you to this quickly. So they're called Siamese twins. I think you're more familiar with that term. And they're basically identical twins who are somehow joined together. Now the incidence is supposed to be 1 in 50 to 1 in 100,000, but actually if you take all those who are not born, that means those who die in the uterus, it can reach up to 200,000 is what they say. That's 1 in 200,000. They're extremely rare. And that's why no center in the world has enough experience with this condition. For some unfortunate, we don't know why reason, the girls are more commonly affected, 3:1. And if you look at the outcome, 50% of them are dead at the time of birth. Some die soon after birth, within a few days after birth, and only a small number survive. And this is for all. But if you take someone with the complexity that we had in our case, the survival is even less than that. So, very rare survivors, which I will show you later. How does it occur? There are basically two theories that they say. So let me tell you this. There's an egg that is formed, or one embryo that is formed, and this embryo can split into two twins. If for some reason they don't split completely, then they become conjoined. They're stuck at some part. The other theory, which is more acceptable is the fusion theory, where they separate, but like cells that like each other across, they come together and get stuck. So they get conjoined again. So these are the two theories that are commonly discussed. Can you move that slide? This doesn't work. Yeah, so which are the common types? Our twin belongs to this type, which is called Thoracopagus. And if you just add the word pagus to wherever you join it, then you get the type of lesion that there is. Can you move the slide, please? This is another example of babies joined at the abdomen and lower chest. This was a long time ago when we separated these babies. They are now young girls in Nigeria. I think some of you will remember them. We presented them to you a long time ago. Next. And this is how they were joined. They had their livers, they had their intestines, and their colons, or their large intestines, also joined. So we had to divide all that and give an equal share to each baby for them to survive. And that's how they survived. You will remember this baby. It's called a parasitic twin, where this baby was born with an autocyte. An autocyte is a baby who doesn't have life, no head, but had a very small heart. But this baby was supporting this whole structure. So we had to separate this whole thing, give the baby back her genitals, colon, everything that she needed at the bottom end. And she's now a young girl who walks around on her own legs. And that's many, many years ago. You remember her that we did it in Narayana Health City, and it was a very sensational case. So based on this experience that we have, I think the government of Mauritius chose us to do these cases. And as Dr. Shetty pointed out, we're very grateful for them having reposed their trust in us. So these are conjoined twins of our type, the one we are talking about, Thoracopagus, where they have a single heart. I want you to look at the right side, where it tells you the survival. There's only one reported cases of survival of both the babies when an attempt was made to separate them. But they had a very minor joining of the top of the heart, so at the atrial level. So, but they lived for a few months and then they succumbed. There are only two reports where one of the babies was sacrificed, if you may say, to save the other baby. And that's similar to our case. So there's not many reports of the type we are talking about. And as Dr. Shetty mentioned, the anatomy in our case was unique. It was extremely complex, and there is no report in the literature of the heart anatomy as complex as the one we have here. Next slide, please. So I don't know if this is showing properly, but I'll try to explain to you. This is how the two babies were stuck, and they had, this baby had a very small size in weight, as well as a very small lung, poorly developed lung. They had a fused liver, and they had a single heart. So what did we do? We kept all the tissues of the smaller baby so that we could close the chest and the abdomen at the end of the operation. So we borrowed soft tissues and chest wall from baby 2. And Dr. Shetty and his team divided all the major vessels of the heart going to the poorer twin. And that is the veins coming from the top, veins going from the bottom, and the aorta, and the big vessels that are going to the lung. So all these were carefully sewed and stitched, and then we waited for some time to see if the baby was stable and well. And when the baby was stable, then we decided to go ahead with the rest of the complete separation and the division of the liver and the repair of the diaphragm, which separates the chest from the abdomen. So it's a very complex procedure. It took many, many hours, it took a lot of work, and it took a big team who participated in the care of these babies. Next slide. I'm sorry, before we go any further, what are the problems that we have? There are many. When did we do it? Dr. Shetty pointed out that we were pushed to do it because the babies were not getting better. One of the babies was deteriorating, so we had to do it earlier. Otherwise, we would like to wait till about 6 months at least to get the best results. Which had a better chance? Obviously, this baby was smaller, the lungs were not developed, and there was problems with the blood vessels of this baby going to the liver and to the lungs, so it made the choice easier. But it took a lot of work on the whole team, including my other colleagues in the medical departments, to talk to Mr. Ian and his family to understand that if we undertook this separation, that we would lose one baby. It's very hard because when they came from Mauritius, the first thing that Mr. Ian told me, "Doctor, can I take both my girls back?" And it took me a lot of work for him to understand that we could not. Just this complexity, we could only possibly save one. And thankfully, after all our efforts, we now have, next slide please, we now have baby Clear today, bright, talking to her father very often when he goes and visits, she'll be playing with him, and this is how complex it was at admission. And so I thank you for your time and listening, and later on, if there's anything that you need to clarify, my colleague Dr. Sanjay Rao, who speaks Kannada brilliantly, and Dr. Sheshamaya, and others will clarify these things. I think next, Dr. K. Dr. Maya, if you could.
See, I think I'll just briefly explain how the normal heart works, then it will be easier for you to understand regarding children who have decreased oxygen supply or blue child. So this is how the normal heart works, and you can, sorry, one back please, yeah. And you can see the blue blood which comes from the body. It is then pumped into the lungs, that is the lung artery, and you get oxygen in the lungs when we breathe, and then the good blood comes down back to the heart again, and it is pumped all through the body. So the heart is like an engine which pumps the used blood to the lungs so that we can get oxygen, and then the good blood to all the part of the body. And that is extremely important for all the cells to survive and all the organs to work. Now some children can be born where the lung artery is small. So when the lung artery is small, the blue blood does not have any way to go forward. So it mixes with the good blood if there is a hole on the top or on the bottom, and hence these children are blue. Now, if we have to do any intervention, we see how blue they are. Is there significantly decreased oxygenation? And if it is, you have to do something. Sometimes it can be so critical that there is no lung artery which is connecting at all. So then what happens to these children? Now, there is a God-given tube which you see from the top here, which is called a Speedy, and the blood comes from here and goes to the lungs, so there is some degree of oxygenation. did traditionally for these children is they had surgery, what we call a Speedy Shunt. So the surgery was done from the side or from the front. And the surgeon put an extra tube here so that the blood can come down to the lung arteries and they can get some oxygenation. What we do now is, in the last 3 years, we have gone ahead and we work along with the surgeons, and these are called hybrid procedures because we work with the surgeons so that both of us can reduce the number of surgeries and the time for the surgeries as well, so that we can come up with newer techniques. So I'll just show you briefly. You can see here, this child was born, this is the lung artery here. You can see how narrow it is, and there is hardly any blood flow going to the lungs. You don't see the lung fields at all. But see the next one. You can see we have put a stent here, and you can clearly see the lung arteries filling up very nicely. And this one was just done through the vein from the top, so no surgery at all. So, you can avoid surgeries. So coming to the conjoined twin, which we have here, you can see that they are connected, and a part of the heart is here, and the part of the heart is here. Extremely difficult. They don't have 4 chambers anymore, they have 7 chambers, 6 to 7 chambers. First of all, you need to sort of get a grip on where different arteries are coming, where they are joining, and which is the heart which you're going to save. Here, when you're born with 6 or 7 chambers, you cannot make both the children survive because there is not enough chambers for the heart to fill in and pump. So you need to decide and you need to come up with a plan. So we had an extensive discussion. Dr. Shetty, myself, the radiologist, Dr. Sudesh Prabhu, who isn't here, is a cardiac surgeon who helps us with a lot of hybrid procedures. So then we decided that we're going to do a PDA stenting here because of the complexity, so that this child was getting bluer and bluer, as already they have explained. So we needed to buy some time to separate them so that the children grow. Now, how did we keep them, how did these children survive till then? Until then, we were giving them medicines to keep the PDA open. But you cannot do that forever. So we had to come up with a plan. So it was quite difficult because you need to know where to go because there are multiple arteries coming from different chambers. So we decided, and we have a very good anesthetic team who gave us the access, because first of all you need to get an access to get into these arteries. Dr. Sudesh Prabhu, who made a cut down here from the artery so that I can come from the top. So there were a lot of people who were involved here. And you can see a small tube here. That is the PDA. That's the reason I showed the cartoons before. And this is the lung artery down. See how it is not filled much at all. And this is with the medicine. This was with the medicine. So that was the tube which was giving oxygenation for both the children, not one. So that is the a small tube which was giving supply. So you can see the small tube again, which is here, and you can see the lung artery. So once we put a stent in here, you can clearly see now increased blood supply. It is, you can see the lung artery is totally. So again, no surgery was needed. We avoided surgery because we could come from the top. And how did we do this? Because we've been doing many of this for the last 2 to 3 years. We do about 60 to 70 a year. And that experience helped us. It is not that you could not go and do this on this child directly. No chance. So, and I always say that, for us, most important thing is the institution support and encouragement whenever we come up with innovative technologies and everything. And there has to be a clear-cut preoperative assessment and strategy, because if that fails, what are you going to do? So you need to come up with a backup plan, A, B, C, and you need to have a very good team around you who will help you throughout. Thank you.
I now call Dr. Narayana Shetty, our intensivist, head of PITU.
Hi, I'm Rian. We are all, we call pediatric intensives because we look after children who are critically ill. So our team essentially consists of nurses and paramedical staff, and then we are supported by the length of other teams you saw, the many other teams you saw there, who support us 24/7 whenever we have trouble to get a few procedures done. So, since 2001, Narayana, the pediatric ITU, has saved more than 50,000 lives of children requiring cardiac procedures. So we have gained a vast experience in children. And hence we have developed a large multidisciplinary team capable of supporting critically ill children. What we have essentially done in the last 5 months for Clea and first few months for her twin is kept her going, as in kept her alive, so that we come up with ideas first to do this stenting procedure, and then come up with this thing where we can separate them. All this is only possible if we have a very strong intensive care team. So this conjoined twins has actually brought us a unique challenge. It's given us a unique challenge for the whole team. The job of the intensivist is to make sure these babies are monitored 24/7, their medications are titrated, their ventilatory settings are titrated, and when to get them out of these supports, keep them as stable as possible before they go to the ward and then finally home to live a full life. This is a great big challenge. Luckily we are blessed with very hard-working, motivated, enthusiastic young nursing and a paramedical team, which you cannot forget here, who looked after Clea and her twin very closely, every second for 24/7 at the bedside. What was unique for us is that they were joined, but we had to treat them separately. So they had to be attached to separate ventilators, they had separate infusions, they had separate drug charge, they had separate monitoring. 2 different nurses. But when they get unwell, we still have to think they are one, because they are sharing a lot of things. So every time they get unwell, we have to rack our brains to make sure that we're getting everything right. So whatever we give to one baby used to go to the other baby, obviously. So it's been an amazing journey for us. It's been very rewarding for all of us in this team. Just to summarize quickly, they came when they were 14 days old. That's 2 weeks. We kept them alive with the medication for 6 weeks, and then we did the PTA stenting, which Dr. Maya explained. Then our goal was given that we should keep them going at least 6 months. We were hoping at least 3 months. At about 2.5 months, we couldn't go any further. So we are having multiple meetings, and then we decided on a day, and we separated the twin, and you saw the photo of Clea. So as of now, Clea is feeding by herself, is gaining weight. She came to us as a 2-kilo baby. She's almost getting 5 kilos. She's going to celebrate her 5th month soon. She's smiling, interacting with you, missing her mother obviously, who's not here, and is breathing by herself with very minimal supports on the ventilator. We're just keeping the ventilator on because our wonderful friends from Mauritius are here. She's going to go back home on Friday on the flight. So for that journey, we're keeping her on the ventilator. Once she goes back to her home, they will make sure that she comes safely out of the ventilator. That's the live pictures. Can you show me the last one picture, still picture, and I'll just explain and I'll speak. So as you can see in the left,
please play the video clip also.
Yeah, that's a live. Keep it on.
Hello. So they are connected over here. These two are the tubes that go into the mouth, which are actually just a few centimeters inside the trachea, maybe a centimeter. So anything would have changed in all this 120 days, that would be disastrous. So they are connected to 2 different ventilators, one going this side, one going that side. They have lots of identification to say who is who. They are colored. They've got a lot of stickers so that we don't mistake. And then we have lines coming out underneath here. We have lines coming out here. There's some lines over here to give all these medications to keep going. Every day we had to flip them upside down because they should get pressure sores. And this was essentially done by nurses. At that time, we have to make sure all this don't come out. If anything comes out for a few seconds, that would be it. So it was challenging, but very rewarding. And this is how she looks today. And then we'll also play the live pictures from the Pediatric IQ. Thank you very much, everybody, for coming here, being a part of this, spending a valuable time here. Thank you.
Dr. Ashley, would you like to introduce the doctors from Mauritius?
These young gentlemen are leaders in their country for intensive care. And they traveled when the babies came the first time.
And Madhu, can you stand up? This guy hand ventilated the baby all the way from the airport to Narayana when the babies were sinking. And he brought the babies just at the nick of time so that we could take over and save. And now he's come again with the blessings of the government to take the babies back. So I think you should give him a... So, open to question and answers. And anybody have any questions to our doctors? Fourth set. And one baby, as I showed you, who had a parasitic twin. So from the very beginning, the fourth. This is the only one from Mauritius. There's one from Nigeria. In Benin City from Nigeria. And the others were local.
So what's the future now? I mean, how does this baby in future respond? I mean, her heart condition and other things. How do you... Does she need more medical attention, more treatment? How is the future for her?
Thank you. Good question. See, she has a tracheostomy now, a tube in her trachea. And as Dr. Rian pointed out, that is for the safety and for her transport back. Slowly that will be weaned off. She'll breathe on her own and the tube will be taken out. After that, she'll be breathing normally. Because they were lying in the womb together joined in one position for 9 months, they developed certain rotations of the spine. So those rotations of the spine will slowly grow out. As she grows, they will become more straight. And there are very many procedures which by braces and by molding that we can make her straight. From the heart point of view, as Dr. Shetty pointed out, is a very complex heart. You have to see how it behaves going forward. It will have to be assessed periodically. Maybe she'll have echoes and various tests, and they will send us the reports. And by telemedicine, we will be in touch with them. And our team will be very willing to give them any help that they want in looking after this child as she grows. But historically and from the literature, there are babies with these complex anomalies who have grown up to being teenagers, and they are well. So there's only one baby of that nature from the one I showed you. And a lot of the conjoined twins have grown up and have babies of their own. So, but this being so complex, we have to monitor very carefully and see how she does. Like that.
The problem with this baby specifically is that she's a unique child with single ventricle. So this baby at some point of time can become blue gradually. If that happens, we have to do the first stage operation. Then we follow up again, and there is a possibility that the kid may require a second, third stage operation. Yeah. But right now the baby is stable, we'll allow the baby to grow. We constantly watch the saturation. and it may require a staged procedure in the future.
Sir, was this condition not identified in the early stages of pregnancy, like through ultrascanning or something like that?
Sir, supplementing to him, what is the root cause for this thoracopagus? No, I asked you, you didn't know about this.
Good morning. This problem was not identified during pregnancy.
Not identified. They knew that they were getting twins, but they did not know that they were conjoined. It was a great surprise to them.
Why was it not identified on through ultrascans or something like that? Is there a difficulty in that?
Normal pregnancies with ultrasound scanning depends on so many variables. The weight of the mother, the distance between the probe and the baby, the position of the baby, how you can get windows, as they say, to look at various parts. So in normal pregnancies, people make suboptimal sort of diagnosis. So here you can imagine with the complexity where we spent, I think, about 4 echocardiograms and multiple imaging studies just to understand the anatomy after they were born. You can imagine how much trouble they had in utero.
I would just say that, there is a specialty called fetal echocardiography, where we look at the heart in detail. So we could know 90 to 95% of the diagnosis when the child is in the womb. But there are very few people who can do it, and we are blessed that we have a fetal echocardiography unit. So to the question, can it be diagnosed? Yes, it can be diagnosed now, but there are very few centers who can do it.
Sir, how expensive is the whole procedure?
See, it is very expensive because we looked after the baby for nearly 5 months in the ICU, and ICU care, as you know, is very expensive. But the message I would like to give you is, if a child is born with conjoined, the problem like a conjoined twin requires a complex problem. There are very, very few hospitals in the world which can perform the procedure. And it is expensive, but as an institution, we will offer our services whether they pay us the money or not. We have got a phenomenal team of people who enjoy taking care of these critically ill kids, and we can perform the procedures. But if you ask me how much it's going to cost, it is very expensive.
I know. Yeah, thank you, sir. Congratulations to your team.
How many hours did it take, sir? You didn't mention that. The entire surgery.
I think the surgery starts with the children going to theatre, then getting anesthetized, then the operation, and then coming out. So the whole procedure took about 8 hours thereabouts. The operation itself was about maybe 5 or 6 hours. So it's just just shifting them from one room to another room is a big process because of what Dr. Ryan mentioned. There are so many tubes, so many connections. So just moving them from place to place has to be a pre-planned. You do dry runs, you do mock trials, you do shifting mock. So there's a lot of planning that goes in. So the whole operation itself took that time because of all the work that went in beforehand in terms of trying to plan everything and trying to set up everything.
How are you shifting the baby? Is it special air ambulance or special medical, support that is being given to her while she's being transported?
I think Ganesh or Ryan, you want to say something about plan for shifting the babies?
So we've been in constant touch with the Mauritian team. They've come and seen Clea about a month back, went back and reported the details. They've come back now, they're staying with us now. They have even attached their own ventilator yesterday. And they're due to fly on Friday. All the requisites for that has been sorted out. Yes, it will be a commercial airline, but a few seats will be converted into like an air ambulance. And they are flying in Air Mauritius. They're going back. And there are 2 doctors to look after the journey back.
They're very precious, so they'll get maximum looking after. Sure.
Very curious.
See, the surgery, of course, is complicated, but we could perform the procedure mainly because of the wonderful team of intensivists who kept the baby alive, especially Dr. Ganesh, who is here, who's our pediatric intensivist. It was a great challenge, and they are the ones who made sure that the kid was kept stable and we could operate. And we can today do any operation because all I do is to do the operation and they take care of the babies.
I'm Dr. Ganesh. I'm one of the intensivists. I want to say thank you to Dr. Shetty sir and Dr. Ashley sir for giving our team a team of intensivists and believing us that we can do it. Because one day Dr. Shetty sir has sent a message saying that we should go ahead and do it. And many days we did not have sleepless nights. It's very nice, but as Ian said, like, it's really, really rewarding for our team. And our team has grown up after doing this 3 or 4 levels higher in the quality of care we provide for all the babies we take care. Thank you, sir. Thank you, Mr. Ian. I have been talking to Mr. Ian. He's a father and who has been wonderful parent we could have. So every day you will come. It's all yours to take care. I believe your team. That's what this is. And thank you for everyone from the Mauritian team to believing in us. Thank you.
And first of all, let me thanks for the team for what you done for the baby. And all the doctors, including Baru Sol, and also a new friend, all the doctors here, thank you for what you done. After so long time I was searching for a girl, after 3 boys, and you gave me the opportunity to have one. Thank you very much, and may God continue bless you in your work. Thank you very much.
Turn, come, here, Dr. Ganesh. So, come, one question. Come here, come in this. Yes, this is one picture. Come, that's something that's come back. Here, come, everyone. I show you a photo. I show you a photograph. You visit that we have 25 people.
Hello, excuse me, madam.
Excuse me.
Madam.
All right.
Hello.
Hey, photo.
Thank you.
Oh, madam, please come back. Yeah, you waited for.
Thank you so much. Thank you.